All right, so again, I have my video off, but you guys, I'm gonna share the screen with you, so you're seeing antihistamines. There's two classes to antihistamines. So when you're thinking about them, if you're being tested on them, or even if you just want to review antihistamines, what collectively, guys, what can you tell me? What do you know about antihistamines regarding mechanism of action? Okay, that could be. Well, let's talk about Benadryl. We'll start with Benadryl. Let me pull this up here so you guys can follow along exactly what I'm talking about too. Okay. Hang on. If this wants to load. At the bottom. I'm like, where is it at? All right. You guys all see the screen pretty good? Let me turn the light on. So when you think about antihistamines, first thing that comes to mind is allergic reaction, right? How you can use this, how is this clinically relevant? It's relevant because you may see a patient in anaphylaxis, okay? Yes, an anaphylactic reaction, you're gonna need epinephrine. But if it's a reaction that's happening maybe outside of anaphylaxis, we're gonna go with an antihistamine, right? It can help negate inflammation. It can help decrease pruritus, which is itching. What about urticaria or urticaria? Hives. Right. It's going to work on hives. And how it's done, antihistamines, as you see in the picture here, I've got some pictures that they're found within mast cells. They're found within the body. They act as a neurotransmitter. When we have mast cells, that's another marker for inflammation. Well, how does these cells get inflamed? How do they create this urticaric or wheals or hive reaction that you see the patient presenting with, right? You see them with hives everywhere. Well, why is that? We have to get on a different level first to understand how this works. So it starts with basophils. You see he's carrying around histamine. Can't really read it, it's kind of fuzzy up there, but his weapon of mass destruction is histamine. Just picture basophil walking around the battlefield of the body, and all he's doing, he's got histamine. He's just waiting to just sling out there and cause vasodilation, which increases the blood flow, which now to the site of infection or the area of presentation, you're going to have redness, you're going to have warmth. Okay. Basophil is responsible for those signs and symptoms of infection. So when we're answering these type of questions, we need to break down these pharmacology questions. Okay. And just understanding the patho behind it will help. This takes it kind of back to the microbiology level, which ideally every course should be a reminder, but that's okay. We're going to work with what we got here, okay? So these are abundant regarding mast cells, nose, mouth, feet, internal body surfaces, and blood vessels. What it says there in gray, it's kind of hard to read. That's why you get anaphylactic reaction in the airway. Makes sense now why we're so worried about airway when we have people that are having these reactions, because they're mostly found, especially mast cells. Basophils will irritate the mast cells, they swell, then you have your inflammation. Okay. When we talk about H1, they have different, their antihistamines have actually four different drug classes, but I'll start with the H1. H1, again, works on smooth muscle, brain. It says here endothelium. Don't worry about that right now. That's the internal, the intuna of the blood vessels. Okay, just the interior portion of it. Then you have your H2s. Remember we were talking about ranitidine, famotidine. Those are some examples of H2 receptor blockers, aka an antihistamine, because it works on the gastric mucosa. Also works on cardiac or the heart muscle, and of course your mast cells in the brain. So while we're thinking of what's going on, we need to consider patient presentation versus medication choice. Okay. Not that you'd be practicing medicine, but this is where the questions come. What would you anticipate? This is your critical thinking. It could turn into a priority question depending on what's happening with your patient. Okay. We like to give antihistamines as what they call a first line therapy for what you call allergic rhinitis, what you know as a runny nose, a clear runny nose. Okay. Can this drug class make you drowsy? Absolutely. These will make you drowsy. Okay. But I'm gonna scroll down kind of out of order real quick because I want to show you the signs and symptoms. They also call allergic rhinitis. You may see this on a test question, hay fever. Okay. But we don't like to give these to people with asthma. I'll get into that in a second. I'm skipping around for good purpose here. Two computers. I'm sorry. Okay. You guys have heard the drug class anticholinergic. What does it mean to you? Right. None of that.
Pee.
There is no peeing. There is no spitting.
What is the other?
Oh, you can still eat.
Was it pee? Can't spit,
Can't see. Got blurred vision.
No, that's what it is. Can't see.
There you go. All the S's. I won't get into the S's, but we will talk. So I'm going to use the example of Benadryl. Diphenhydramine is the generic name for it. Okay. It's classed as an antihistamine, but it's even further classed as an H1 or antagonist or an H1 antagonist. Okay. These have some strong sedating properties, meaning if you give someone a Benadryl, be mindful that they're going to go sleepy sleep in just a minute. Benadryl is also found on something in your drug book called Beers criteria. You guys ever heard Beers yet? Dr. Beers was a physician and he said, hey, if you give Benadryl for people in the geriatric stage of their life, 64 or older, and or 64 or older with maybe confusion or a raging UTI or encephalopathy, you're going to create a problem and it's potentially hazardous for them, meaning it's going to have an alternate reaction. If you give Benadryl to a child, what happens? Who's tested those waters?
They're more hyper.
They're hyper, they're excitable. They don't go, some of them don't even go to sleep. Some do.
Got that video?
Idiopathic reaction, it can be considered one. But the thing is, we know why it happens, but it's not warranted. We don't want that. We want them, we may need them sedated, but and again, for Beers criteria, so if you're reading your drug book, why it's relevant? If you're reading your drug book, when you're a fresh new nurse out of college, your drug guide should be readily available on you. Okay, maybe even afterwards, it's okay. You cannot know every drug class or every med. You should know a little bit about each one, but there's gonna be times I've had to do it 100 times. You've got to go look it up. I've never gave this. Hold on, let me go look this up. Okay, and you don't have to feel lesser of. Look it up. It's a resource. So let's keep going with this. Your side effects of these are dry mouth, constipated. It can cause a rapid heart rate. Here's where you have problems. You have this cognitive disturbances that come into play, blurred vision. So think about a geriatric patient with a UTI and they're getting a little agitated. Benadryl may not be the way to go. If they have hives, if they have pruritus, maybe from a reaction to another medicine or food, may want to consult with the doc and see if there's any other alternatives, maybe even something topical. Okay, maybe like a hydrocortisone, depending on the area of insult. Where is it happening? What's going on? If it's systemic, we're going to need a medicine orally or IV, because topical is really for what? It's a localized area. So it just depends how your patient's presenting. We try to go what? Least invasive first, right? So when you get these questions, you can think about ABCs. You can go into Maslow. Normally, if it's a farm question, it is memory recall of the drug class though. If there's a scenario to it, you can utilize some of these different strategies to try to answer the question to the best of your ability. But I can guarantee you, if you've got one that's talking about a patient with a elevated ammonia level, or a patient with a white count of over 10 and they have a UTI and they're a geriatric patient, this is not going to be the criteria to go with. Or somebody with they're dehydrated, because what's that going to do? It'll make it worse, right? Absolutely. Glaucoma. These have some extrapyramidal side effects here. Okay. This might be considered off-label, but some of these can be used for an antiemetic. So if you got nausea, vomiting going on, right? Some of these can be used, but you use them with caution. That falls on your nursing judgment, your critical thinking, your knowledge of pharmacology. You know, like I said, each med, you cannot know each med. Keep your drug book with you, but know how to use it. That's the key. Know how to use it. If it says Beer's criteria, research it. What does it mean? Or remember, go through your notes. What you can do is, if you've got a patient with a UTI and they're a geriatric patient, you do have an alternative you can use, which is called an H2. Let me go back. You have what you call H2. These are your second generation antihistamines. There's some examples. Loratadine. Anybody know the brand name of loratadine or loratadine? Nope, that's loperamide. That's a mide. This is a dime. When I say it, you're gonna be like, oh my God, I need that. You were saying it. No, no. We're on antihistamines. We're talking about allergies. You want me to tell you? Okay, I'm gonna tell you. Think about a non-sedating allergy medicines all over the TV.
Have it in my
A Claritin. It's a Claritin. Okay. Notice what it ends with. It's dine, zyme, and time. Okay. If you can remember, if you're an endings person, that might be the way to remember. These are the H2. These are second generations. They're not as sedating. That's why they say take a Claritin daily. You're not going to fall asleep with a Claritin.
No, that's just my face fun.
May want to talk to your doc. That's not.
I took it twice and my entire face was just like closing.
You may have an allergy to that medication.
Yeah, I was gonna take it again.
Okay. Good thing you didn't take it again. So these have, whereas H1s, your Benadryls, your diphenhydramines, the mines, okay, they can cross the blood-brain barrier, potentiating sedative side effects. So if somebody's having allergies or a reaction, but we don't want to really sedate them, or maybe they're that confused geriatric patient that we don't want to potentiate their side effects, a second gen might be good for them. Okay, that H2. One that is approved by the Pediatric Medical Association. It's a Pediatric Association of America. They've approved Ceftonir. Hang on, it's another one. Zyrtec. They've approved Zyrtec, which is Sertrazine. Thank you. For use in pediatric patients. That's why you can give a peds patient, just to relate back to peds, an H2 second generation. Okay. Doesn't really make them as drowsy. Can they get a little drowsy? Maybe minimally, but not like a Benadryl will knock you out. Okay.
So
Like, could we think of between the first gen and second gen as first gen maybe for more acute allergy and second gen for like seasonal allergies? I don't know.
Well, they can both be used kind of the same way. A good way to remember these is which one's going to put them to sleep or not. That was just my suggestion. But you can get creative, guys.
So first
Think about
gen
it.
is
Sedating.
drowsy, second gen is not drowsy.
Right. First gen, nighttime. What happens at night? Sundowners. What happens with sundowners? Confusion. Don't potentiate it with a first gen. Give them a second gen. They're going to be awake. They're going to be way less sedated. Doesn't cross that blood-brain barrier. Doesn't negate or potentiate any confusion. Okay, but again, you can get as creative as you need to, because each one of us has a different learning style. Okay, but if you remember those medicines and their endings, it's going to work a lot better for you. Okay, you've got some other ones here too. Let's talk about these now. We want to always be cautious with these with blood pressure, people with high blood pressure. Okay, because these can act as a decongestant. You guys ever seen like Claritin D? Well, that has a decongestant in it, and decongestion with hypertension doesn't mix very well. You're going to potentiate their high blood pressure and shoot them up for a little bit. You're gonna elevate their pressure. You want to be mindful of that when you're using or selecting these medicines. Critical thinking. When you use these, if it doesn't have a decongestant mix in it, it won't give you that rebound hypertension like the ones with a decongestant. Decongestant hypertension, no go. Absolutely not. That's like with Sudafed, not good for your hypertensive patients. It's not. You want to stick to a Coricidin, okay? Which has a different decongestant in it, which won't spike your blood pressure, give you headaches or a rebound. Okay. And it's pretty cost effective too. Coricidin has now got some new highlights, and they have now moved up from the bottom shelf. Now they're like mid shelf. I think they pay for all that. I don't know how that works, but it's certainly available. It is over the counter, and you can advise your patients on there. Don't worry about this CYP inhibitors. I'm not going to go into that. That's not a little too deep there. Also with these medicines, they kind of work along the lines of a proton pump inhibitor, but not really. They will inhibit gastric secretion, gastric acid, your hydrochloric acid. They'll kind of put it on hold while it's in the system, if you will. Okay, so brief reduction of gastric acid. If you are giving these patients, just make sure to get a full medical history within the question that you're answering, or if you're using this while you're working, just make sure you think of asking them and assessing their medical history. Hold on, I'm just catching up my screen here. All right, now let's talk about toxicity with these second generations. Something you may see is convulsions. You may see maybe an unbalanced gait, whereas it was balanced before. Lack of coordination, fever, because of its slight anticholinergic properties, you drying out the body, right? And cardiac arrhythmias. I put cardia, it should be act. Anyway, so those are things to just be mindful about. We don't like mixing these with certain antibiotics. It says here macrolides and azoles. So if I'm giving antifungal medicine, like not fluconazole. Hold on, it means with an M. Well, I'll just say antifungal medicines. Don't mix them. You got to space those apart because they inhibit each other. Mostly the second generation will inhibit antifungals or your macrolide antibiotics. Okay. We can do tutoring on anti-infectives another day. Maybe next week we can get into those. Let's keep going with this though. Okay. I'm gonna bring it back to first generation, like your Benadryls, diphenhydramine. So your means, here's an example. You got some meds here. Hold on. Sorry, two screens. Here you're gonna see Benadryl. You're gonna see promethazine or promethazine. That one really is used for an antiemetic. RN's in the room. You guys might be giving this one day, very soon. And what cautions would you want to be mindful of if you were doing this as an IV infusion? What's your thoughts? You can talk. What? Let's think if I'm doing this IV, what consideration should I have for a side effect within the integumentary system or the vessels?
What's that word? Is that something? Not that good.
Well, not phlebitis. It can relate to extravasation, especially if so extravation, right? It's the IV catheter has gone through the vein and it's causing the promethazine to leak into the tissue. Infiltration can cause tissue necrosis. People can end up with a skin graft if something goes wrong with this. We don't like doing this IV. Have we done it? Absolutely. Have I done it myself? Yep. Was I nervous the whole time? You bet it. Okay. One. H1. H2 is your second gen. Okay. But yeah, you want to be extremely conscious. This can come in a suppository. You may want to coerce your doc if he's so kind or she's so kind to order it like that because it is high risk into a vessel. So when you are infusing promethazine, what you want to do is you want to get a larger vessel because it doesn't do well, right? The more distal you're on, okay, the more distal, what happens to the vessels? It gets smaller. You want a nice wide vessel. Now we teach you to start at the lowest point for IVs, but here's your critical thinking coming in, your judgment. What medicine are you giving? That needs to be in a larger vessel higher up. I always suggest follow policy and procedure where you work at too. Okay, cover yourself. What else? Hydroxyzine, that can be for adult and pediatric use. This is a generic form. Let me think of the name. Is it Visceral? Think so. Again, I have to look it up. It's been a minute since I gave hydroxyzine. It's liquid. Comes in a suspension, comes in pill. Yeah. So you want to be mindful of giving this. It does have sedative properties. What else? Meclizine, that's another one. It's an antiemetic, but again, it's a first generation antihistamine. These are some of your alternate uses.
Well, these ones that are right here, they're all first gen,
Yes.
but I thought designs were considered H2.
Some of them. That's where it can get confusing at. So only some. These, again, learning them by drug class or making individual drug cards on some of these that share certain properties would be helpful. There's not too many of these. These are the most predominant ones. Okay. I had to make individual drug cards, but that was just me. I couldn't do a drug class on these. It was a little difficult because the way they share certain side effects. You want to be cautious again, hypertension, CKD, right? Because it's anticholinergic, it's drying. COPD, right? If they can't, we have to think about considerations. We don't want to dry them out. Dries up mucus, that becomes problematic. Thyroid disorders and closed angle glaucoma. I think if you just remember glaucoma in general, you'll be okay, whether closed or open angle. Whenever you're giving these medicines, again, just analyzing them, and this is probably going to be the tail end of this too. you want to analyze exactly what's happening to the patient if you're applying this as a test taking strategy for farm. Meaning, read the question twice, answer it once, read it backwards. Does it say need for further teaching, or is it asking you a priority type question? All right. Hold on. One more thing I wanted to discuss. I did not talk about H3 and H4. I just want to keep it simple. We really won't get into H3 and H4 in the ADM program. I do like to talk about it because you may see this. Your H3 and H4, they can be related to a patient feeling full. There's some new research studies coming out. This is just optional evidence-based. I'm just sharing. So there's some research coming out for obesity treatments. So if they give a patient an H3, it can potentiate feeling full or satiety. Right, just interesting. I figured I'd share that with you guys. And last one I'll share. Let's see here. Catching up the video too. If a patient is, let's say, allergic to iodine, but they have to go to a procedure that must use iodine, you can pre-medicate with an H1. This could be like a priority or a critical thinking question. If you know they're heading down for maybe, yeah, a CT that has to use contrast media, pre-medicate them. Okay. Yes, now they do, but not at all facilities. Right? Do you guys have any questions on antihistamines? Did this clear up a couple questions about that, or help you learn about antihistamines? Did I confuse anybody? All right. Yeah. Like I said, we all learn differently, but I'm going to try to touch on some drug classes. I talked about metformin earlier. I have another PDF for metformin. I will send out. It's kind of similar to this one. It's not as long. It's kind of short and sweet. But we'll work on it. I will send you stuff. If you guys need anything, Tuesday, Wednesday, Thursday of this week is the only week I'm out for 3 days PTO. So I just want to pre-warn you guys. If you need anything, reach out to Assistant Dean Luminosa or Dean Rivera. Just for the next 3 days. All right.
Are you going to, you said you were going to extend the first one, right?
I am.
Okay.
I am.
So if we.
No, I haven't. I'm going to go to my office next, but I will